Okay, welcome. I want to welcome you to peripheral arterial disease. I'm John Adams, and I'm a vascular surgeon here at St. Mary's. And first of all, I'd like to thank all of the attendees for registering and attending this webinar. So we're recording this, and we're going to send out a link at the end. If there is any problem with uh, the viewing of this, then please let us know if you would over the chat mode. And also, when we send this out as a link recorded later today, you're going to get an invitation to join Friends of St. Mary's email. And I would encourage you to do that. That entitles you to a lot of information about what we're doing at St. Mary's. If you have any questions during this presentation, please use the chat mode. And I'm going to answer the questions at the end of the talk so that we kind of continue to flow during the lecture itself. So with that, this is the presentation on peripheral arterial disease. Okay, and I'm trying to, okay. So I've said that I'm John Adams, and I trained in Texas. I grew up in East Texas, and I trained in Dallas. I went to college at Baylor, and then went to the University of Texas Medical School in Dallas, and then also stayed there for my general surgery residency at Parkland Hospital. And as many of you may recall, Parkland is where they took JFK when he was assassinated in Dallas. So there's certainly a lot of history there. I then did a fellowship in vascular surgery at the University of Missouri in Columbia, Missouri, and I have a lot of fond memories of that. And as we had always planned to go back to Texas, my wife and I had 3 young children and another one on the way. We loved Missouri, and so we stayed here. And so I've been in the area since the late 1990s, and I love St. Mary's Hospital. And the reason that I'm coming to you today is because I am employed by SSM, which, as you know, is the owner of St. Mary's of Jefferson City. And so the culture here could not be better. We have an incredible facility here. If you haven't visited St. Mary's in some time, it's a new hospital, which was built, I think, in 2015. And so with that, let's start this peripheral arterial disease lecture. And I am trying to turn the slide. I'm going to invite. So just like surgery, things don't always go as planned. Okay, so this is my family, and I want to introduce you to them. You can see me on the front left, my wife on the front right. She's been my childhood sweetheart since the 7th grade. We've been together for quite a long time. Unfortunately, my mom had been deceased by the making of this photo, which was just a couple of years ago. But you can see my dad in the middle on the back row, and then my 4 children, who I'm extremely proud of. My dad has been a constant source of mentorship for me throughout my life, and I would not be where I am today without my dad. And so I call him more than weekly and thank him for that. He is still on our ranch down in East Texas, and I was going to be a rodeo cowboy until he told me that, hey, you're going to make something of yourself and you're going to go to college. And he's actually the one that although I filled out the application when I graduated from high school, 2 years later, he's the one that activated my applications and sent me to college. And as I said, I'm eternally grateful for that. So my family is a constant source of inspiration, and I really owe a lot to them. I owe most of my success to them. Okay, so sorry about that. I'm just learning how to change slides. So the topic for today is peripheral arterial disease. It's known by a lot of different names. You may have heard slang terms such as hardening of the arteries, peripheral vascular disease, or vascular disease. But all of these go by atherosclerosis, or the etiology for all of these terms is atherosclerosis. And we're going to delve into that in just a minute. But peripheral arterial disease is extremely common in our society. So if you look at the statistics involved with vascular disease, then you're going to see that cardiovascular disease, or CVD, is the leading cause of death globally, accounting for almost 1 million deaths in 2021, and certainly exceeding that in the current year of 2025. Stroke accounted for 163,000 deaths in 2021, so that's 1 in every 21 deaths in the United States. Peripheral arterial disease, and we're talking about that entity which affects the blood vessels throughout the body. So peripheral arterial disease affects the blood vessels in the heart, the brain, the peripheral arteries, and so forth. And the prevalence of that is about 200 to 500 million worldwide. So it's a very common problem that we have. If you're in that American category that's over 60 years of age, then lower extremity, or LE, lower extremity peripheral arterial disease, affects about 12 to 20%. The prevalence, if you have diabetes mellitus and you have a DFU, which is a diabetic foot ulceration, is about 40 to 50%. So if you have a risk factor of diabetes mellitus and you have an open ulcer, then you're about 40 to 50% is your risk of having peripheral arterial disease. In the United States each year, about 150,000 patients develop limb-threatening ischemia, and of those, about 20,000 people lose their limbs secondary to amputation. So I don't expect you to really recognize a whole lot off this slide, and this is a very involved and complicated slide, but I throw it up because it is what we know about atherosclerosis. And really, there are only a couple things that you really need to take away from this slide. One is that cholesterol is ingested by what we call foam cells, and they can be a lot of different cells that ingest cholesterol. And it then allows the ingestion of cholesterol and the cellular movement across the inner lining of the blood vessel, across the intima. Remember that the blood vessels are made up of 3 different components: the intima, which is the inner lining, the muscular media, and then the outer lining, or the adventitia. So these cholesterol-laden cells, if you will, move into the media or into that space between the intima and the media, and they set up residence for plaque. Remember that atherosclerosis is a disease of inflammation. And that's why when you go to a physician's office with complaints consistent with peripheral arterial disease, they're going to measure blood tests which reflect an increased level of inflammation in your body. So not a whole lot to take away from that slide, except that the high cholesterol levels move across by a cellular mechanism into this intima media space, and that it's a disease of inflammation. So atherosclerosis is the primary mediator, if you will, of PAD. So normal is on your left, and the normal flow of blood from the heart out to the tissues and to the organs is a pretty uniform thing. But as we build up plaque, which you can see on the right, we call that an atherosclerotic artery, and it leads to decrease in blood flow. And the top panel on your right, you'll see a longitudinal section of a blood vessel. And in the bottom panel, you can see a cross section. So we've cut the artery end on, and we're looking at the artery end on, if you will, in cross section. And you can see that that plaque is encompassing and obstructing blood flow through that artery. It takes about a 50% decrease in the cross-sectional area to decrease the blood to the extent that the patient knows what's going on, has symptoms, which we'll talk about in just a little bit. Well, this is a pretty important slide, and it's been reproduced many times over, but this is one of the early slides by the SAGE group of a study that they did back in 2010. And it shows that compared to a normal population, which you see at the top of the graph in the clear circles, it shows the mortality or the death rate of someone with peripheral arterial disease. And you can see that if you have the clear triangles, which is an asymptomatic peripheral arterial disease. So you've got plaque inside your arteries, but that plaque is asymptomatic for all practical purposes. It's not causing symptoms that we're going to talk about in just a moment. That you have a decrease in more mortality. And if you have a symptomatic peripheral arterial disease, you can see in the black colored in boxes and in the triangle colored in boxes that you decrease mortality even more, or your longevity is decreased even more, I guess I should say. So that if you have severe symptoms from your PAD, at about 5 to 6 years, your mortality is about 50%. So your death rate's about 50%. So that's pretty important to us. And it's been building up for years and years and years, and we can track that longitudinally through different symptoms that the patient has. And that's what we're here to talk about today. So risk factors for PAD, first and foremost, nicotine usage in any form. Second, third, and fourth are diabetes mellitus, high blood pressure, and high cholesterol levels. And then sedentary lifestyle and aging, which we can't do anything about, plays into that as well. Importantly, if you have greater than 3 of these risk factors, greater than 3, then your risk for developing PAD is tenfold compared to the normal population. You can see at the bottom, obesity. We're going to talk a little bit about that, but a lot of people feel that that's a risk factor. And then there's some very rare genetic disorders, such as Ehlers-Danlos syndrome, Marfan syndrome, et cetera, which can be associated with PAD. Now, a lot of people come in and they have a very strong family history of PAD, and that's really more of an association than it is a risk factor. In other words, they have risk factors in their family, such as diabetes, high blood pressure, high cholesterol, et cetera, and therefore they're at risk for PAD because of their inherent risk for these risk factors. So what can you do? What can I do to avoid PAD? Well, first and foremost, correct the risk factors. And a big part of that is avoiding nicotine, and we're going to talk a little bit more about how to do that. But you have to decide, hey, nicotine is not good for me. Too much caffeine is not good for me, but really it's the nicotine. And so that's something that is an individual decision. You have to correct or control your diabetes, your high blood pressure, and your high cholesterol levels, and your weight, which goes along with that. And a lot of people do that independently. More frequently, that's done with the help of the primary provider through medications and strategies and things like that. We're going to talk a little bit about that as well. Walking or an exercise program is very important. I'm going to show you what exercise actually does down on the blood vessel level. So walking is very beneficial. What am I talking about? I'm talking about 20 minutes per day, brisk walk, trying to elevate your heart rate to about 60% of your maximal heart rate. Remember, maximal is usually 220 minus your age will give you your maximal. So about 60% of your maximal heart rate is where you want to be in this walking program. Primary provider recommendations are really important. They're really necessary. And I would urge all of you, if you haven't seen a primary provider recently, that you do that. And then modification of your diet. We're going to talk about diet modification, what's healthy for blood vessels, et cetera. Well, speaking of diet, there are a host of different diets out there. And I can remember when I was growing up, the rage was the liquid protein diet, which puts you in a ketogenic state. And the only thing you need to know about that is you burn fats as your caloric source rather than carbohydrates. And we've been through a lot of diets like that. And what I'm here today to talk to you about is what a healthy diet consists of, what the American Heart Association recommends, and what is healthy for your blood vessels. So what makes a diet good? Well, I think all of us would agree that if you live longer and you decrease chronic illness, that's a good diet. Chronic illnesses such as heart disease, stroke, diabetes mellitus, cognitive decline, cancers, et cetera, can be decreased with a quote good diet. The other thing that happens with a good diet is you do lose weight. And usually that's at the top of the list, but I put that down here within the list because I think that's less important than the top two. A diet needs to be supported by scientific based studies, and it needs to be absent of any harmful effects. So what makes a blood vessel diet healthy? Well, it turns out that what's healthy for the rest of our body, the rest of our tissues, the rest of our organs is really pretty healthy for your blood vessels. And it's really all those things that you've been told your whole life, but never, at least for me, never really followed. But certainly we need to follow a diet which is rich in vegetables and fruits. Plant-based proteins are probably better than animal-based proteins, and beans and lentil fit that bill for plant-based proteins. Whole grains, oatmeal and brown rice, and then a diet that's high in, if you're going to use animal proteins, unsaturated fats, such as pork and fish, as opposed to red meat, which are saturated fats. So we want a diet low in that, low in processed foods, low in sugars, and we want to match our activity to our caloric intake. It doesn't do us any good if we're on a diet that is supplying 5,000 calories a day or even 4,000 calories a day, and we're burning 2,000. So we have to match that intake to activity. I think that just makes intuitive sense. Well, the Mediterranean diet is a pretty good one to follow. And it's actually consistent with American Heart Association recommendations. It is good for vascular health and your vascular system, obviously. There are a lot of important parts of that, which are eating plenty of fruits and vegetables, legumes, nuts, beans, peas, etc., and use of olive oil for cooking rather than lard and things that all of us were raised on. We want a diet which is rich in unsaturated fats, such as fish and pork from animal, and then plant-based proteins, such as avocado, the different seeds, and so forth. Interestingly, when I was preparing this, I saw rapeseed oil in a lot of different diets, and I got to be honest, I didn't know what rapeseed oil was. And so rapeseed oil is that oil that is gleaned from, if you will, mustard plant and cabbage. And in Canada, they use that a lot. And in fact, canola oil is named after Canadian-based oil. It is made in Canada, and that's what canola oil is. So I didn't know that. Hopefully all of you knew that. So we want minimally processed foods. We want it to be low in high carbohydrates. We don't want to drink 2 liters of Pepsi a day. We want it to be low in high fat dairy. And this always makes me chuckle because when my kids were very young and they used to go visit my parents in Texas, they would eat 3 meals a day ice cream because my dad got to eat ice cream. So he loved it. They loved it as well. So this Mediterranean diet is consistent with American Heart Association recommendations and is a great diet for you and your blood vessels. We're going to talk a little bit about what each of these risk factors for PAD does to your blood vessels. And high blood pressure or hypertension is one thing that makes your arteries stiffer. Now, a technical term for that is decreased compliance, but the bottom line is it makes them stiffer. And when they're stiffer, they're more apt to have tears of the inner lining, the intima. And they can be either small tears, micro tears, or large tears, macro tears. And when that happens, it is easier for cholesterol to gain access to that space we were talking about across the intima, the inner line of the blood vessel, and sometimes into the media as well, to set up this whole stage that we know is atherosclerosis or plaque formation. We know that high cholesterol is not a good thing. We know that bad cholesterol is LDL, good cholesterol is HDL. And the higher your cholesterol levels, the more apt you are to exhibit problems with PAD. And I just turn your attention to the top right, in which you see a healthy blood vessel on the left, and then the precursor to plaque, the fatty streak, on your top right. And as a matter of fact, if you take young individuals, young adults who are 18 to 25 that get killed in motor vehicle accidents, and you do autopsies on them, you will see the precursors of atherosclerosis. You'll see the fatty streak. And that's an awful young age for these individuals to exhibit that. And the reason is because of our culture here. I mean, we all eat chips, we all drink soda, we have a terrible diet, and down the road, we're going to develop problems, and we probably have some problems even at that early age, but just don't know it. Bottom left is the fibrofatty plaque, and that's just a progression of atherosclerosis in plaque form. And then that can become a complicated plaque. Now, we did a surgery this morning on an individual who we were cleaning out the artery. And when we cleaned out the artery, there was an evidence and a little ulcer in the middle of the plaque, which had embolized, which meant that little pieces of that plaque had broken off and gone up to this gentleman's brain, as a matter of fact. So these things can cause problems, not just in the obstruction to blood flow to the target organ or the target tissue, but they can also embolize with little pieces breaking off from the plaque and going downstream to the tissue or the organ. So obesity, a lot of people ask me, is obesity really a risk factor or not? It's hard for me to answer that because we have this thing called the obesity paradox, which just means that we're not really sure. There are some authors who have postulated that obesity confers a protective mechanism for peripheral arterial disease. So is it just an association by nature of our bad diet and our diabetes and all the other risk factors that we have with PAD, or is it just an association with that? And we have studies that are very conflicting. We do know that obesity causes health problems, specifically joint problems, diabetes, pulmonary difficulties, etc. And if you want to try to figure out if you're in that category that you need to even worry about that, then there's a thing called the BMI, Body Mass Index, BMI. And BMI is a calculation of height to weight. It's a crude calculation, but it does help us to understand whether or not we're in that category of obesity, morbid obesity, severe morbid obesity, etc. And if you have any questions about that, certainly I have a wheel that I use, which is the calculation, but the calculation is pretty easy to find on the internet. So this is a study in which a colleague of mine who's a vascular surgeon named Caitlin Hicks at Johns Hopkins University reported a study in the Journal of the American Heart Association in 2018, and it's called the Atherosclerosis Risk and Community Study. And basically what she did is she took, it ended up with 15,000 adults and longitudinally studied those over about a 30-year period. And what she found is that patients who had obesity developed peripheral arterial disease independent of these other risk factors. And I'm not going to bore you with all the findings of the study. You can read them here. But it does help me to understand that, yes, obesity is a risk factor. And when we're talking about all these other things, then certainly I think it behooves us to talk about obesity as well. So what does exercise do on your blood flow? Why is it so good? Well, if you look at this pane in the top left here, you can see that this is a normal individual who's got kind of some streaking and so forth, but certainly nothing that we would call significant PAD. And basically their pressure at the top of the blood vessel is 120 millimeters of mercury. Their pressure at the bottom of the blood vessel is 120. So their pressure, say up in their thigh, may be 120, and their pressure down at their toe is 120. So they really don't have any obstruction of blood flow. These vessels that you see out here to the side are called the collateral vessels, and they have normal to scant flow in them in this particular state. But as you exercise, then you open or you secrete nitric oxide, and nitric oxide helps you to open these prearteriolar sphincters. And when you open those up, you dramatically increase the amount of blood flow through these collateral blood vessels. And so now we're in a situation where this is a patient who doesn't exercise, 120 at the top, 60 below, so 120 in the thigh, 60 down at the toes. And after exercise, you can see this is 120 at the top. And I don't know if you can see this down here because of my picture, but it's basically 80 to 100. And you can resolve any problems that you have with exercise through the collateral blood flow in these blood vessels. And it's due to the effect of nitric oxide dilating up these prearteriolar sphincters. And this all goes back to Purcell's law. I said when I was in college, I would never use that term again, and here I am talking about it. But Purcell's law basically says that everything is dependent upon the radius of the vessel. So if you decrease the radius of the blood vessel, you have to have collateral pathways to get blood down to the tissues. It's kind of like a stream with a beaver dam. If you've got a beaver dam that's blocking everything up, then you're dependent upon these little creeks and streams that come off upstream of the beaver dam and then flow into the river below the beaver dam. So that's what we're doing here. We're basically affecting the collateral blood vessels in such a way that they can supply oxygen and nutrients to the downstream tissues. Okay, let's talk a little bit about nicotine. Nicotine, in my practice, is one of the things that is really tough. And I remember a study when I was a resident from UCLA in which they gave rats, now basically rats, not humans, but rats. And they gave rats the choice, and they could have nicotine as a diet, they could have cocaine as a diet, or they could have heroin as a diet. And guess what? Rats chose nicotine over starvation, as their diet, over cocaine and over heroin. So it's probably the most addictive drug that we have, dating all the way back to the 1950s. You can see that we knew it was harmful. The Surgeon General's report came out in 1964, which is interesting to read, but we know that nicotine is harmful. I mean, I don't think any of us would disagree with that. I think it's an individual choice for whether you abstain from nicotine. It certainly plays into if you're having problems from PAD and you want to get better, you need to stop your nicotine intake. There are more than 20 free apps on your iPhone to help you abstain from nicotine. Most recently, we know that behavioral therapy, group therapy, hypnosis, and some medications that we use can be advantageous for having someone decrease or even abstain from nicotine. And those medications we prescribe in our clinic, such as Zyban and Chantix. We used to do that more so before the group and the behavioral therapy and the hypnosis came about in the mode that it currently is, but that's still an alternative. So what does nicotine do to the vascular system that's so bad? Well, this is kind of getting scientific, but I just want you to realize that it has effects on the inner lining of the blood vessel. It has effects on our circulating constituents called platelets, and it has effects on the cholesterol, and it actually decreases the good cholesterol. Nicotine does a lot of bad things to the inner linings of your blood vessel. It's the number one far and away reason that people have PAD. A little bit of a shout out to my alma mater, University of Texas Southwestern in Dallas. And they have the Howard Hughes Research Center. And these are two individuals there that discovered the nicotinic receptor. So currently those medications I just mentioned, Zyban and Chantix, don't actually target the nicotinic receptor. When this came out in 2016, I really was excited because I thought, okay, well, it won't be long before Big Pharma comes up with a medication that we can use to actually attack the nicotinic receptor and do a much better job. Currently, if you put someone on a medication and you enroll them in group therapy, the abstinence at 1 year from nicotine is about 12 to 15%. It's terrible. And the reason is because of the addictive nature of nicotine. So hopefully at some point we can get around to a medication which actually attacks the nicotinic receptor. So what are the symptoms of PAD? We know what it is. We know what the risk factors are. We know kind of how it works. What does that mean for us? Well, I've divided that into three big categories. So the first category obviously is not on here, and that's asymptomatic. And we've talked about young individuals who have that. But when PAD starts to cause problems with symptoms, then the earliest symptom is usually claudication. Claudication is an exercise-induced cramp of the lower extremity, which is relieved by rest. And usually patients will tell me, hey, used to I could walk a mile every day, and now I can walk about 200 yards and I get a cramp in my right calf. I have to stop and rest. It goes away after 5 to 7 minutes. I'm therefore able to walk another couple of hundred yards before I get this problem again. That's claudication. It doesn't happen, it doesn't occur usually unless you're exercising. Rest pain, on the other hand, is when we've stepped up a category and we now have pain of the right lower extremity or of a lower extremity at rest. I'm sorry, of a lower extremity at rest. It could be either one. And the usual story is that it occurs at night. And the reason for that is because we don't have the gravitational force. We don't have gravity to help us with our perfusion, usually of the legs, and it usually happens in the feet. So the usual story is I get up 30 minutes after going to bed because I'm in a recumbent position and I'm not using gravity. And after 30 minutes, I have to get up and walk around. I have to get gravity to help me get my blood down to my feet, and my rest pain goes away. And then it accelerates to where I now have pain all the time during the day, et cetera. And that's when patients typically come into the office and they think that they have a neuropathy or something like that. And in fact, they have PAD. If left untreated, that can lead to tissue loss, ulceration, and gangrene, which basically is just loss of the tissue or the organ downstream from the PAD. And usually in my practice, that's lower extremities. In almost all vascular surgery practices, that's lower extremity. Oops, sorry. Okay, well, okay. All right, I'm back on track with you. Okay, so I put this slide up because physiologic data is important, and you're going to hear these terms if you go to visit a vascular surgeon. Physiologic data has to do with things like ankle brachial indices or ABIs, waveforms, pulse volume recordings, toe pressures, transcutaneous oxygen pressures, TCPO2s as it's known. And basically what this is the ascertainment of blood flow through your blood vessels. And we use a handheld Doppler. It's non-invasive. There are no sticks or anything. A handheld Doppler is basically just going to emit sound waves, which are reflected by moving objects. It bounces back to the transducer within the Doppler, and you hear that as an audible sound. And we're comparing normal flow in the arms. For some reason, PAD doesn't usually affect the arms. It can, but it usually doesn't. And we're comparing the normal circulation, which we usually find in the arms, to an abnormal circulation down the legs to figure out, is this PAD? So I don't want to get into the physiologic testing of that, but I do want you to be aware of those terms because you're going to hear those. Imaging data. Once we figured out what you have, it's good to image those vessels before we do some kind of intervention. And in most cases, as I said, we're not doing an intervention. So you would only get the imaging data if we're going to plan an intervention like an ultrasound for an imaging data, or duplex as it's known, or a CTA or an MRI, magnetic resonance scan. MRI means magnetic resonance imaging. MRA is magnetic resonance angiography, or some other type of scan. The CTA uses contrast and regular X-rays, and the MRI uses magnets to help with the transparency of the tissue. Excuse me. Okay, so this is what we're trying to avoid, and we're trying to avoid tissue loss or gangrene. And in this particular patient, you can see that we have advanced to gangrene of the foot. This is a patient which, if we traced it back about 6 months, we would probably find out that this patient had rest pain and then progressed to this because of no treatment. Believe it or not, this patient walked into my office the day before this picture was taken and said, hey, I think I've got a problem with my foot. My foot's not the right color. Yes, you've definitely got a problem. So how do we treat patients that come into the office with symptoms? Well, as we said with claudication, I mean, we never, very rarely, if ever, do we ever do an intervention. We're going to correct the risk factors. And because we know that their risk with no treatment and just correcting risk factors, no intervention, I should say, no intervention, but just correcting the risk factors, their risk is about 1 to 2% per year for loss of tissue or an organ system. So when someone comes in with claudication, in general, we try to correct those risk factors. And we said nicotine intake. We want to control their diabetes mellitus, their high blood pressure, their high cholesterol levels. We want them to lose weight. We want them to get on an exercise program. And probably the two most important factors are abstaining from nicotine and an exercise program. We rely very heavily on the primary providers to help us with controlling diabetes, the high blood pressure, the dyslipidemia, or the high cholesterol levels. And we do that because we just don't see them very frequently to keep tabs on those things, whereas primary care providers can set up a schedule and a strategy to keep very close tabs on those. We know that there are some pharmacologic agents which are really important, and that is treating those high cholesterol levels with the statin. Statins also independently have a protective effect on the inner lining of blood vessels, so it's good to be on a statin. I have a colleague of mine who's been on a statin for 30 years because he really feels strongly that it's protective for his inner lining blood vessels. We know that aspirin is very protective against stroke, and Pletol is a rheologic agent which allows the blood vessels to squeeze through these tight spaces, if you will, that's created by the plaque, and hence perfuse the downstream tissue or organ system. So not infrequently, we'll try Pletol as well. Well, once a patient has progressed to this thing called CLTI, or chronic limb threatening ischemia, either with rest pain or tissue loss or gangrene, then everything changes. I mean, those patients typically are not going to do well with just treating conservative measures. In fact, they're not going to work. They rarely work. We still do it, but we also have to increase the blood flow to that extremity quickly in order to keep them out of trouble. And if you look at the statistics involved, rest pain, 25% per year risk of amputation, tissue loss and gangrene is a 40 to 50% per year risk of amputation of the limb. So the treatment revolves around conservative measures and intervention. So what do we do with regard to intervention? Well, we typically are using an angioplasty with a balloon or a stent to help us with the intervention, with the downstream perfusion of the blood vessels. We still use open surgical techniques. Just used one this morning in which we cleaned out an artery in an individual who was really not a candidate for a balloon or for stent. We have a lot of different stents available to us. We have a lot of different balloons available to us. And so primarily it's a balloon, a stent, or some type of open intervention. Well, I used to put a lot of really cool movies involving real patients up here. And so I was doing that. And I had a lady in the front row who passed out. And I said, okay, well, that's the end of that. I'm not going to do that anymore because it totally disrupted everybody in the program. So here you have it. These are still pictures. This is a picture on your left of a patient who has a normal appearing abdominal aorta. Now he's got some little areas here which are inundated with plaque, but nothing significant until you get down to this right leg artery, and that's called the common iliac artery. And you can see that we've got a problem here with obstruction to blood flow. It's not completely occluded, but certainly there's a blockage there of about 70% or greater. And so compared to the one on the left leg looks pretty good. So this is a pretty straightforward catheter based case in which the patient comes in and goes home the same day. Procedure takes about an hour. And basically, we've put a stent up in the artery, and this is the right after picture that you can see. So the before on your left and the after on your right of a patient treated with a stent. And by and large, these stents hold up great in the circulation, which is above your knee. Once we get below the knee, stents don't hold up very well, and that's a whole nother lecture. But primarily above the knee, we do very well with stenting and balloons. So starting from left to right, you can see that we have a whole lot of different open and combined procedures available to us. On the far left is a graft. And if you could envision that this artery coming down here, called the superficial femoral artery, down to the popliteal artery is blocked, then certainly one avenue is to put a graft and do a bypass operation. In the middle panel, you can see that we've done a bypass operation with a graft interposed, not bypass, but interposed. And above that, we used a stent. So sometimes we manufacture procedures which are a combination of both the catheter-based things as well as open. And then on the far right, you can see that in the neck, we are frequently treating the carotid arteries, which are the main blood flow to the brain, and by cleaning the plaque out, or so-called endarterectomy. And this is a very simplified picture of what that looks like. So we've come a long way since 2006. This was one of our rooms that we had then that I dug up a picture of. And I think you can appreciate that we have two sets of different catheter-based treatments. We have on the right, way back here, we have those catheter-based treatments, which are catheters and balloons and so forth. And then over here, we have the different catheters and the stents down at the bottom. So compare that to what we have nowadays in the cardiac cath lab here at St. Mary's, and I think you can see a pretty big difference. So we have imaging, which is top notch. We have not just two cabinets, but we have this whole line of cabinets down the left side. And then we have this cabinet down here, and I didn't open these up for you, but they're all different types of catheters, balloons, and stents. And on top of that, not only do we have imaging, which could be CTA, digital subtraction, et cetera. I mean, those are all different types of imaging, but we also have inside the vessel imaging, which actually will be shown on this screen during the procedure. So we can put a catheter inside your blood vessel, and we can measure the blood vessel. We can see the plaque inside the blood vessel, et cetera. And it's really good for sizing stents, especially in some of our vascular systems, which are a little bit difficult to size. Okay, so in conclusion, I'm just about to run over with time here. So in conclusion, I think that PAD is avoided best by correcting your risk factors. Excuse me. And risk factors, we said that first and foremost, there's nicotine, followed by diabetes, followed by high blood pressure, high cholesterol levels, and then aging and lack of an exercise program. So those are really the main ones. And if I could give you any piece of advice, it would be to take care of yourself. I don't mean that you have to go out and run a marathon every day. What I do mean, though, is that you should regularly exercise if that is an option for you. And regular exercise is walking briskly for 20 minutes a day. And when I say a day, I mean 5 days a week. I don't mean 7 days a week. I mean, certainly you got to have rest days in that. Lifelong correction of risk factors and surveillance. Surveillance is important. We do a lot of surveillance here. I have a lot of patients who come in with claudication that we've then corrected some risk factors. They're better. And every 1 to 2 years, they come back and we measure their physiologic tests and try to keep tabs on how they're doing. And I think that early detection of PAD offers the best outcome. I think that goes without saying, but I certainly would tell you that. So I want to thank all of you for tuning in today, and that concludes our lecture for today. And I'm happy to answer any questions that you have. And I I don't know if this was a Freudian slip or not, but I did forget to mention at the outset of this that that can be done through the chat box. And we have one of our administrators here who's monitoring that and taking questions and so forth. So so this is a common question that we get in the office, and it's basically someone has sent in and said, does crossing your legs make your circulation worse? Well, your grandmother told you not to cross your legs, and I'm aware of that because she told me the same thing about every day. But the truth of the matter is, in moderation, in a meeting that lasts about 30 minutes to an hour, I mean, it's not going to make a big difference. The biggest difference you can make is to regularly exercise. And if you do that, then you're way ahead of the game. So crossing your legs is not quite as bad as your grandmother told you. Okay, I think that's it, and that concludes us for today. And I really appreciate you being with us, and thank you very much. I would like to thank the St. Mary's administration for helping put this together. I basically did nothing except show up, and they're the ones who prepared the slides and all the IT stuff. So the chat boxes and things that I just am familiar with the terms, but I don't know what the heck they really mean. And then I also, if you have problems related to this, my clinic is at St. Mary's. It's called the Specialty Clinic. It's 681-3585 is our phone number. 681-3585 with the 573 area code. It's on a lot of your stuff that you have when you're registered. We'd love to see you there. And I'm pretty conservative. I think as this talk bears witness to, and most of the time we can find a conservative treatment for what you have unless you've progressed to one of these problems that we've talked about, like rest pain or tissue loss. Okay, very good. Thank you very much.